All right, so I'm going to start us off with a little video.
What is it?
Explosion at a power substation. Multiple burn and blast victims, 3 minutes out.
How many?
At least 8.
Make sure you clear the trauma rooms. Jerry, get the blood bank to send all their ONEG. And Dawn, make sure we have enough morphine and rapid infusers.
yippee You want to be an ER doc? This is the fun part.
Morris, triage.
55-year-old man thrown 20 feet against the wall. Diffused abdominal pain, BP 80 pounds.
Rigid abdomen, probably spleen or liver. Tracy,
Yeah.
2 of ONEG and hold for the OR.
Open femur, good distal pulses.
Now take this. Junie, grab an ounce of 100 of gin, titrate the laudanum, and call ortho.
Julia, you're up for burn. I got Bardelli's ready. Good.
Found him down a V-tip on a high power line. Epi, lidocaine, 10 shots, put him into a system.
Trauma 2?
No, curtain 3. We have to hold traumas for the ones we can save.
27-year-old male, short of breath, pulse ox 82,
come on.
decreased breath downs on the
No
right.
facial burns.
Pneumothorax.
Okay, set up for a chest tube.
Arm was blown off below the elbow, intubated up to 10 of MS.
All right, Sam. Anything to reimplant?
Bits and pieces.
Go.
Burns over 90% of his body. Should have vocal
All right, leaders and ringers, let's call the burn service. Okay, good.
Check for singed nasal hairs for smoke inhalation. Set up for intubation. 38-year-old man.
That's an oldie, a really oldie. You guys probably weren't even born, or maybe in kindergarten. I'm Alice Lee, Dr. Lee. I finished in 1992, and I've been at, except for 4 years, I've been at Banner Baywood since 92, and then I did 4 years at Chandler in the middle of the 2000s, and then I've been back to Baywood ever since. I'm also a clinical assistant professor over at the U of A, mostly at the Simulation Center. I help with their, the mock codes and their skills labs and stuff like that. And also, one of my most proud accomplishments is I had a blog. I put that on hiatus last year, but I had a blog called IQ on Emergency Medicine News, which is one of the most well-read or highly read online resources for emergency physician. And I'll talk a little bit more about that later on. So today we're just gonna answer 3 questions. One, what is emergency medicine? You guys are in the emergency medicine club. You must have some idea of it, but do you really know what it is? All right, now why would you want to go to emergency medicine? And then I'll touch on how to get into emergency residency. I mean, you can hire somebody to get all the data about that, but anyway. So let's just start with, what is emergency medicine? It's a medical specialty that contains the knowledge, skills, and the art of caring for all health and behavior-related emergencies. Right? It's an art. There's a vast bank of knowledge, and there's a vast bank of skills. And it's to take care of not just medical issues. There are emergencies, there are behavioral, emotional, psychiatric emergencies. So just a very quick intro. Emergency medicine is probably the newest specialty. It began with the formation of American College of Emergency Physicians in 1968. Here's a little blurb.
In the 1950s, advancements in battlefield medicine were brought home to America's hospital system. In the 60s, specialty training began, and emergency medicine was born. Join us for ACEP 18 in San Diego, where we'll celebrate the 50th year of ACEP and emergency medicine. We'll see you there.
All right, so then we understand a little bit about what emergency medicine is, but why would you want to be one? Anybody want to volunteer? Why do you want to be an ER doc?
The variety of care that you have.
Very good. All right, so my first thing, and I didn't coordinate this with him. So for me, I'm going to, I guess I should just say, what I'm listing and what I talk about is a lot from my own personal perspective, but I also think that these thoughts of mine are very common to emergency. Okay, so number one, there's such a variety of patients, right? You've got these seniors, you've got the pediatrics, you've got the trauma, you've got the psychiatric illnesses, and on and on and on, right? It's fast-paced. I'm generally pretty fast-paced and ADD, so it kind of works for me. And you get to use your brains and your brain, right? So you do procedures, you don't just know things, you do things. I love procedures. I mean, I play instruments and I knit and blah, 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 so I love the fact that you can use your brain and your brain, right? You're not on. That got me. All right, and you do save lives occasionally, or more than occasionally at Banner Baywood, where I work, which is a geriatrics ER. And occasionally you have some you can deliver some babies. And it's definitely very flexible in terms of hours, schedules, you know. And then it is one of the better, well-compensated specialties that are available, right? So this is kind of a typical board, tracking board where I work, as well as where many ER docs work. So you can see the age range. Now my ER, that day I took this picture. It was kind of unusual because it's like kids. my ER only sees 5% kids in Banner Baywood. But anyway, you've got the 58-year-old, you've got the 24-year-old, you've got the 14 psychiatric illness there. You've got the overdose, you have the toe pain and palpitations, right? So what's that? So yeah, and is it an adult or a kid?
I did not miss that.
It's a kid because there's a growth plate, right? Okay. What's this? Ow! That's a fracture. It's a periprosthetic fracture of the femur, right? Oh, I hope you see the Goomba in there. Yeah. And there's very few beats on that. Bradycardic. And then what is in that? Any idea? What do you see in that CT scan? What's a big old round thing there? It's a giant aortic aneurysm. Yeah. And then what's this? Anybody? VTAC. That's right. So you've got a smattering of all sorts of problems. So I love cases. I mean, I just love emergency medicine because the cases are amazing. So I'm just going to go through some cases and get you excited about ER, okay? So one summer night, a guy comes in, and apparently he was at a picnic, and somebody put their shotgun leaning against the picnic table, and of course it goes, whoosh, dunk, falls, slides off, and this guy got this buckshot. His friend brought that in, and that's what we opened up to see what it looked like, and that was what it was in his blood and not X-ray. So the surgeon actually took care of it and went inside and just cleaned it out. Now, there's a lot of airway cases where we are. Chelsea can tell you all that. So I know, dear. I know, dear. I'm sorry. Hang on. There's a piece of something right there. I can get in here. I know, hon. I'm sorry. Could one of you grab her hand, please?
You want my ketamine?
You can give her another 100.
Another 100?
Yeah, that's gonna be. It's soft. It's gonna be. Get to that. very soft. I know, I'm sorry, hon.
Just relax. You're doing good.
Oh. Any idea what that was? Piece of tortilla. She was 80, somebody aspirated a piece of tortilla. So what's always great is to see oops, see. I just wanted to show you the anatomy. You can see the airway, the vallecula. Ah, there we go.
There you go.
See that? Say hi. I just wanted to film the airway after we took the piece of tortilla out. Guess what I'm doing? Jaw dislocation. That's right. I was just yawning. And so the technique is to straddle the patient and sedate the heck out of them and then push down and back. Now, in ER, you can do all sorts of things, right? We talked about brawn, we talked about brain. You can do all cool things like reduce a dislocated hip, like the boss. You have to push down.
Push harder.
Yeah.
Push harder.
Yeah, you're doing counter traction.
Okay.
Yeah.
There.
Good. That's awesome.
That is too cool.
That's too cool, right?
It popped right out.
I posted this on YouTube and it's got like 2,000 views or something. Everything else that I posted with like 1 view, but this one everybody loved it. Yeah.
Is the patient asleep?
Yeah. Fully sedated. You have to, like with a person my size, you can't rely on brawn. You just can't. You have to be this finesse, subtlety, technique, patience. And you can demonstrate on Twitter a new technique. And my handle is at azerdocmom. All right.
Oh, there you go. I'm just thinking they would love to see this.
Yeah, it works. I've seen it.
right?
Yeah,
Yeah.
Zosky did it
Tell if it works.
1,
without the medication.
3, 4. Head down. Just hold it up for now.
No, they sure do. We got in the bottle, we got 150 milligrams.
No. Oh. Can you film this? Film this. Oh, nice down. Nice down. Good job.
I felt it. Slow down.
Now you don't feel so crazy
you.
from blowing into the syringe, right?
Thank you for cooperating.
I'm glad it worked, but I felt it slow down.
Right? I saw it just like.
Just
Okay, let's
instantly.
repeat the EKG. Yeah, that's, SVT typically is the Valsalva or adenosine stuff. And then over the past maybe 10 years, there was some studies that came out about this method, which is without medication. So I tried it a couple of times, it didn't work, and then I tried this one. It was my first successful case, and I got it on film. So I was like, yeah, all right.
So did you?
When were you here last? Go ahead.
Did you have the patient continue to blow into the syringe as you were lifting the legs and?
Yeah, so he
finding the
blew,
patient?
and I put him up, and I counted loud for the patient and for everybody, up to 10, I think 15. I didn't know it was going to work. And I just had him continue to blow, and I have had times where I've had him blow a second time because they run out of air. I'm like, just do it again, and let's give it a second try. And there was one time where the second try did it. All right. When were you here last?
Months ago,
What? So we see gross, disgusting things. When were you here last? You know what that is? Those are maggots. Some guy came in with a really bad leg, had maggots. All right, and then in emergency medicine recently, it's become standard to do bedside ultrasound, right? Okay. Take a guess at what this is. Yeah, random detachment or somebody. Yeah. It's one of the easiest ultrasounds you can do at the bedside. There's other ones that we learned at the bedside, but this is one of the easiest ones. I think it's very cool because you're in a geriatrics ER, right? And you can see retinal detachments fairly regularly. You can see that the back of the eye, which is the inferior aspect, there's a flag that kind of comes up. That's the retina. looked right away from the back. All right, now, how are we doing on time? This is kind of a longish segment, but I had a blog for 4 years on emergency medicine news called iCube, which is Impart, Instill, and Instruct, right? Impart, Inspire, and Instruct, and it was case-based. Once a month, I talk to a colleague about a case, an actual case that I see, and we kind of go through first just a clinical scenario, and then I make some teaching points, 2 major teaching points. This is probably my most miraculous case, so I just wanted to give you just a clinical scenario. This is what the pre-hospital, can you see that? This is what the pre-hospital monitor EKG is. I don't know if you can. Yeah. But I had a moment to look at the EKG. This is before he passed out, okay, or went into this sort of seizure-like activity. So we get him on the monitor really quickly on the bed, and this is what we see.
Oh no, that's different. That's not at all what you just showed me.
I know. So we know that something's changed, obviously, because clinically he's unconscious now. So CPR gets started. We see that his course V-fib, and we shock him, and you can see that on the monitor strip. So in the meantime, I intubate the guy during the CPR. He's in V-fib, so defibrillate him at 200. Nothing, right? So we do that actually 4 times in a row. And in the meantime, I've called out for Lido, Amio, Bicarb, just in case it's hyper-K, and calcium, right? So we are doing CPR. We are doing these defibrillations without any effect at all, right? So then I'm thinking to myself, my gosh, what? I'm thinking, I'm going through my head all the things that you had to do for VFib, and I thought, dual pads. Yeah. So that was like my thought. Okay, let's just try. So we slap on a second set of pads. I said to them, put the second pad in the front and in the back, and just let's try the 2 pads, right? So we shock him once. We shock him twice, nothing. We shock him 3 times, nothing. And I'm going, oh my gosh, what's going on, right? And so I actually go out to the hallway and I talk to the mom, elderly mom. I said, we've done everything, and I really don't know if there's anything more we can offer, right? So I go back into the room. At that time, one of the ED techs looks at the pad. He looks up at me and he goes, Dr. Lee, is this pad here supposed to be in the back? I'm like, yes, I told him, one in the front, one in the back.
Oh no.
Yeah, right. So the tech changes that pad and puts it in the back. And now we're shocking him for the 8th time in total.
Yep.
And this is the 4th time of 400 joules. And we're roughly 22 minutes into it, 25 minutes into it. And we shock him, and I look on the monitor, and for the first time, I actually see a rhythm. I actually see this very slow Y complex rhythm, and I'm yelling, is there a pulse? Is there a pulse? No pulse. So I'm like, okay, epinephrine, continue CPR. And we go another 2 minutes of CPR like they recommend, right, in ACLS. Yep. And now he's got a pulse, and he's got a pressure. And we get an EKG, and he's got an ST elevation STEMI.
Wow.
And then I call out the cardiologist who happened to be in the ER. So I show him this EKG. Yeah, exactly. I show him this EKG, and he goes, oh, that's a STEMI. I said, yeah, we just...
I was just showing it to you for your opinion. I didn't know what it was. Tell me what it is.
So, happy ending. After the stent, this is his EKG.
That's amazing. And,
I know.
And you had been out there talking to his mom about how nothing else was possible. And now you get to send her son home to her. That's amazing.
Right. Isn't that a shocking case? It's such an amazing...
Have you been planning that fun for a few weeks? The shocking case fun?
Oh, well, yes. No pun intended. But anyway, it is a shocking case. So then, long story short, or short story long, he actually left the hospital reportedly neurologically intact 2 weeks later. Okay, so there's more of that. I edited that out, but each of the iCube episodes are about 20-25 minutes. There's 48 episodes. It's on, you can just search iCube Alice Lee. You'll find it's the first thing that pops up on Google. It's on Emergency Medicine News, and I'm very proud of it. There are real cases, and I really try to teach sort of the clinician's aspect and clinician's point of view, because when you go through schooling and all the academics, especially now you guys, the first 2 years are very mainly just academics. You don't really know the clinical aspect and the subtleties, the nuances, right? So I was trying to teach sort of the way the clinicians think. So there's lots of cases that you can go through where you have like a uninteresting Saturday night, you can just spend your night with me, okay? All right. So I just want to just throw in a little humor here.
So I finally park, I go in to check in. They ask the most insulting question when you check into a hospital. What seems to be the problem? What seems? Well, it seems like everything on my inside wants to be on my outside. But I'm no doctor. What kind of condescending question? So they check me into my luxurious half room. There's a curtain down the middle with a mystery patient on the other side. And he's moaning over there. Thinking, man, they're never going to help me with him moaning like that. So I got to out-moan him, Quit moaning, we're all hurting.
All right. Now, I showed you all sorts of things that are wonderful about emergency medicine. Just remember, I've been an ER doctor 30 years, okay? There's a lot of years without those wonderful cases. But I want to talk, the next thing I want to talk about is that why wouldn't you want to go into emergency? There's lots of specialties you can go into, and you choose it based on multiple factors, including your personality, your interests, the kind of life you want to lead. I've listed a few things that I think that we have to be sober about in terms of the reality of emergency medicine practice, okay? So it's high stress. There's just no two ways about it. It's just a very high stress job. I mean, you could be nothing for a minute, and then the next thing somebody is crashing in front of you, right? So you are going from like normal homeostatic cortisol to lots of cortisol and adrenaline, right? We have to make decisions most of the time without complete information. So, you guys are in the ER club, so you probably have some feeling and some affinity for it, but people who can't do that tend to be more other types like internal medicine and maybe, those kind of doctors to just be more secure with more information. But we have to make decisions with limited information, okay? And sometimes those decisions are life and death. It's unpredictable, like I said, it could be nothing, and then all of a sudden somebody's crashing in front of you. And like I said, critical care, life and death decisions that you have to make all the time. You've got to meet anxious people, patients, and even their families, right? And do that routinely on a regular basis every day. And then it's potentially dangerous. Fortunately, I haven't been injured, but there's been some close calls. It is one of the specialties with the highest rate of malpractice, so that's always in the back of your mind with every single patient. 2/3 of your shifts are actually evening, nights, and weekends. The ER is open 24/7, right? And unfortunately, it does have one of the highest rates of divorce and suicide among physicians, all specialties. So I see a few ladies, which is good. There were 2 females in my class of 8. But I think nowadays, it's more than 50% of residents and medical students are female, so that's great. So I believe EM is a great specialty for us, for female physicians. The flexibility is great, that be able to go to if you plan on having kids, to be able to go in the middle of the day for activities instead of having a 9 to 5 or 8 to 6 job, right? You never have to be on call. Did I say that at Grammy? Did I say that already? I think yes, I did already. So, and then camaraderie, right? Back when I started, it wasn't as much, but definitely nowadays, there's just so many female emergency physicians, and we share very similar and almost identical struggles sometimes. So it's great. And then income is one of the higher ones, and it does help with the stressors of being a physician mom, which is, don't tell the guys, but it's harder than the guys. Okay? But for women, same thing, the females, it is one of the more stressful specialties for women that want to go into like peds or whatever. The schedule is irregular and you have to work a lot of night shifts, which I hate but never have to do again. And it is, again, the higher rate of divorce and suicide among the general female population. So just be mindful and aware of that reality. And then you do miss a lot of family time. You do miss a lot of holidays. And it can be physically exhausting. I mean, doing your 10, 8, 12-hour shifts, 8 hours shift don't usually end at 8 hours, right? So why would I encourage you to do emergency medicine at all? Well, I love emergency medicine. I started my practice, I finished residency in '92. I started my practice in July of 1992. I still love EM. I still do. And that there's another entire talk about wellness and how to be resilient, you know. But I'll do that another day. It is a very, very rewarding career. I don't have any regrets about choosing medicine to begin with, and then choosing emergency medicine as my specialty. I don't have any whatsoever. And as physicians, as emergency physicians, and just physicians at all, make a difference, not just to, you know, locally, but you can, if you choose to do international work, you can definitely make a big difference internationally as well. And the emergency physician can alleviate pain and suffering in the moment, right? Instead of calling a prescription for somebody who has to pick it up later, the patient's in front of you, you can order the medicine. They're in a lot of pain or whatever, you can treat them and alleviate their suffering right away. And you can give patients hope by the procedures you do, whether it's reduction, whether it's a suturing, simple suturing, whether it's releasing pus from an abscess. It gives them hope that they'll get better, right? So, and then of course we're known for saving lives, right? So we do save lives. I think one of the best things about emergency medicine as a specialty is that we are, as they say, the safety net, right? We can help the poor, the unrepresented, the helpless. Doesn't matter if they have money, they have no money, whatever their politics are, whatever their hidden private lives and secrets are, we still treat them the same, everybody the same, okay? And for us, the provider, the physician, it does give you financial stability. And you'll be the most interesting guest at the party. You will have stories galore, and they will be riveted to you. So here, this is a quick thing. How to become an emergency physician. You know, all that is college, 4 years, medical school, 4 years, 2 more years for you guys. And then there's residency, mostly 3 years now. When I started, it was a 4-year residency. Quickly, my personal educational journey, I went to Stuyvesant High School in New York City, went the science, math high school they had to test into. I went to Cornell University as an undergraduate biology major. I spent 4 years at SUNY Upstate Medical University. That was my medical school. I spent 1 year as a surgical intern at Brown University. And then I spent 3 years at Maricopa Medical Center as an emergency medicine resident, and that's where I graduated in 1992. All right, so we've talked about what emergency medicine is. We talked about why you would want to go into emergency medicine, and I've talked about why you wouldn't. Talking about the realities of being an emergency physician. And then I said I was going to touch base a little bit about residency. You know, there's a lot of information online nowadays, I'm sure that you can look up. And I honestly, I looked into residency because when I did I didn't match in medical school. I wanted to be an orthopedic surgeon. Shocking. I was misguided, but I didn't match after 9 interviews, right? So the dean called me in the night before match day. Say, well, this is what happened, blah, 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 you have a choice to do this, and I chose to do a surgical internship. So then I do that internship that year, and that summer, I don't think I told this story to anybody, very many people. But anyway, that summer as an intern, I happened to rotate through the ER, like in September. And I loved it. Again, I loved it in med school, but I loved it again. And my attending just really really thought highly of me, recommended me for this residency. That's how I got this spot. So I don't have any real personal advice in terms of the specifics for residency, but I do have some just general thoughts and advice. Your job as a medical student, I think, I've always thought this, is to learn the basics called emergency medicine, knowledge. Okay. If you want to do EM, even if you don't want to do a specialty, your job is, as a student, is to learn and build that foundation, build that knowledge base from which you will make all sorts of decisions, because you're going to go back to that when you have a conundrum and you don't understand something. Okay? So I believe that's one major thing. You want to be very enthusiastic and helpful to your attendings once you're on the rotations. Not just ER rotation, but of course in the ER rotation, but all your other ones. And just be enthusiastic and helpful if you can, okay? This is just general advice. Stop that, right? So judgment is critical. Grow your mind and build your character as a person, as a physician, all right? Your interviewers and your colleagues will want to work with you. That's what you want to do, is impress those people that you interview with and your colleagues that you're working with. Develop mature and good character. Exercise, diet, and sleeping habits are so important. Now there's a whole discipline about shift work, and how to recover from that. But exercising is important, and then making sure you're eating properly, because this is a marathon, right? A marathon. I'm almost at 26.2 miles. So it's a marathon, and if you want to succeed and get to the end, you want to develop good habits all along the way, right? And then basically be like Kelsey, that's all, okay? So, were you paying attention? That's my little summary slide. What is emergency medicine? Anybody? What's emergency medicine?
Fast-paced field of medicine that accompanies a variety of specialties, all specialties.
That's right. You take care. You are the best doctor to take care of the first few hours of any emergency, right? The first few hours of any emergency. A very broad number of emergencies, right? Why would you want to be an ER doc? Well, all those cases, right? Fascinating cases. You can do procedures, you can use your brain, you can use your brawn. Why wouldn't you want to be an emergency physician? Well, I think everybody has their own reasons that they wouldn't want to, probably. And then how do you become an emergency physician? I touched on that only because I do not have a lot of detailed advice to give you that you can, I'm sure, find along the way.